Welcome, everybody. We're going to have a great grand rounds this morning, but before we start, I have quite a few announcements here, so let me get started on those. First off, I wanted to thank Mary Kate and Kate Bellevue for really helping get a new, I assume, annual conference going at Children's Hospital, which was in honor of Jacqueline Perry, who I think people in my generation and above know as a pioneering orthopedic surgeon who, when I was a resident, actually would come every other year and lecture us on rehabilitation issues and prosthetic issues and issues related to polio that the expertise for that didn't really exist anyplace else locally. And so Kate and Mary Kate have helped Suzanne Yendow organize the Perry Initiative, which is to celebrate women in orthopedics. So thank you. A couple of other announcements. We have a few anniversaries today, and the first one is Connie here? No? So Connie Huey is one of our PAs, and I think everybody knows Connie is a jack of all trades. She works at the Bone and Joint Clinic, and she does total joint orthopedics. She does spine with Dr. Wagner and really fills in for whatever we need. And so this is Connie's 5th year with us, so congratulations, and we really appreciate her help. And the nice thing about Connie is that she worked as an MA in the clinic, so she's actually been with us for quite a bit longer than 10 years. 5 years. The second one is for Alex Bertelson. I know Alex is here. So Alex has been here 10 years, and I think everybody knows him as sort of the pseudo-attending of the shoulder and elbow service who has worked with Dr. Mattson ever since he's been here. So congratulations. Thanks, Alex. And the last one is for Doug Ichikawa, who received accolades from actually many of our patients, and the most recent one said he is flexible, approachable, and always willing to see his patients regardless of what time they show up for their appointments and regardless of how late they are. So Doug, thanks for that. And there's an interesting thing about Doug that was just in the Seattle Times, and he has the most interesting way of commuting to work every day and then back home. Where is Doug? So did anybody see that article? No. So there was a nice, if you know who the Seattle Sketcher is, he's in the Seattle Times and intermittently publishes these really nice colored sketches there, and actually has a coffee table book of them, which is really nice. So somehow the Seattle Sketcher found out about Doug's unique method of travel, and Doug actually takes a kayak from Juanita to Magnuson Park, and then from Magnuson Park to, where do you go with your bike from there?
Bike down the Burke-Gilman.
Bikes down the Burke-Gilman Trail and locks up his bike, and then I believe he actually jogs the rest of the way to work and then reverses that on the way home. So we need to get you a plaque for that. So today's topic is orthopedic care in the developing world, overcoming challenges, as usual, it was organized by Neil Tarabadkar, and our speakers are Dr. Bransford, who we all know, and he's been my friend and partner for probably about 20 years now, and Carla Smith, who's one of our former residents, and Carla also did a trauma fellowship, and she is here. Hi, Carla. And she's been heavily involved in overseas orthopedics also. And then our resident who has organized this is Calvin Schlepp.
Thanks for the introduction, Dr. Chansky. So we'll be talking about this topic, and I'll be honest, my portion of the talk is a little less interesting than the other people or the other members of the panel. So we'll try and get through it, but my goal really is to set the stage, and this is a topic that's pretty interesting to a lot of people in our department. There's actually pretty much every site we go to, there's somebody that's actively involved in this. But I'll be using Malawi kind of as an example, both from personal experience there as well as that it represents a country that is pretty compatible with a lot of places of the world as far as socioeconomic issues and access to care. But we'll start kind of globally with the global burden of disease. Briefly, Malawi, just to get you in a reference point, has about 17 million people. It's in sub-Saharan Africa. These people live mostly on subsistence farming and fishing on about $1 to $2 a day. But there's also some very beautiful parts and wonderful people that live there. A lot of what we know about the global burden disease comes from this series of articles published in The Lancet, and this is a large international group, but this is really headed up by Dr. Murray here at the University of Washington in the Department of Global Health. To understand this work, you really have to have a basic understanding of the metric which they use, which is a disability-adjusted life year. This cartoon kind of plays it out pretty simply, but essentially disability-adjusted life years is a way to measure the totality of disease burden in an individual over its lifespan, both in illness and in the disability related to the illness, as well as factoring in early death. For example, this patient had a nice, healthy childhood, had some sort of injury or illness a couple times throughout life, eventually had some event which resulted in lifelong disability, and then died at an early age before expected. You can calculate this over an entire population. There's the formal formula is below, and there's lots of variables, and there's some controversy in how to calculate this, just like many of the metrics that we use. But one of the principles is the like is like principle, which is somewhat controversial, but allows us to compare diseases between different countries by assuming that someone with a below-the-knee amputation would have a similar level of disability in any country. That allows us to generate this disability weighting, which is done by a number of studies and consensus, but it allows us to categorize things and then place them into this formula to assess their total burden on a population. But for example, in the middle here is below the knee amputations, and things that are more severe like, things that are more severe like active psychosis, quadriplegia, obviously have a bigger impact. We're also able to factor in ages, specifically ages over populations, considering that some of the developing world has a larger portion of people under the age of 18, and gender issues. When you put all 291 of these diseases together, you can and lay it out on a map, you see a common pattern we see with other socioeconomic issues, but developed countries like North America, Western Europe, having generally better overall health as compared to places in Asia, sub-Saharan Africa. And if you actually look at the numbers, the disease burden in these different areas is about 3 times as great. You can also look at this by diagnosis, and for the interest of the people in the room, lots of musculoskeletal things come up to the top. So low back pain, neck pain, falls, osteoarthritis. And if you notice, all these things are increasing rapidly. In fact, one of the most rapid growing groups is this other musculoskeletal, which is congenital and injuries, and has increased at 80% since 1990. If you add in these people, so these people that die early, some of this falls out, but there's another one that kind of pops up that's interesting, which is road injuries, which is also increasing rapidly, and I'll talk about it a little bit more in detail as an example. This is a picture of Malawi. It's a place called Cape Maclear. It's very hard to get to this place. There's actually only one road. There is a boat to get here, but it's a nice place to get some rest and relaxation if you're in the country. The one road is about 7 miles long. It's dirt. The only way to get there is to go to the gas station, ask for the shuttle, pay them a couple dollars and wait for your shuttle, but then your shuttle arrives and there should be some red flags, but you really need of an R&R. So you look and you see that this shuttle has wood, some tanks of gasoline, and then if you look closely, this is actually a box of matches, and these are your seat. So some red flags should show up, but it does kind of show the representation of safety variability, and this may play some part of a role in the increased risk of having sort of significant traumatic complications. Although that's a lighthearted story, this is a big deal. So there's 1.3 million deaths due to road traffic accidents a year, and it's actually the leading cause of death in 15 to 29-year-olds, and many, many more injuries. The cost is really staggering, $50 billion worldwide. In fact, this cost is so great that in some countries, the cost of taking care of road traffic accidents actually exceeds the amount of foreign aid that they get from other countries for healthcare. Most of these deaths actually occur in these low and middle income countries, which have limited access to surgical and trauma resources. And about half of them are vulnerable users, as in these people here that are trying to sell mangoes on the side of the road, or pedestrians or bikers. It's such a large deal that the United Nations actually declared this decade the decade of action for road safety, and working with groups like the WHO have come up with action plans. Most of these things are based on public safety issues and public health interventions that are quite cheap and effective, like safe roads, vehicles, and drivers. But they also recognize that it's really important for the post-crash response to be both effective and available. So after I've covered the burden exists, we also have some information that doing care in these settings is actually valuable. A lot of this comes from this other journal, this other article that was published in Lancet, but actually covers the cost effectiveness of surgery of all different types of subspecialties, but they did a nice job of summarizing orthopedics. These are the 3 studies that are available that we know of that assess cost effectiveness. And what they're able to show is that between $361 and $500 per cost for disability life year saved, that's actually pretty valuable. And if you reference that to other things like taking aspirin or beta blockers to prevent disability from coronary artery disease, costs about $500 to $700. Antiretroviral therapy is $450 to $650, and probably the most available and accepted surgery in the world is the cesarean section. It costs about $320. So we compare quite favorably. Now that we know that there's burden and that it's also valuable to take care of these patients, the next thing is execution. And probably the biggest issue with execution is the limited access, particularly healthcare systems, orthopedic trained individuals, and supplies. This is a study that was co-authored by Dr. Mayer, but compares 3 trauma systems throughout the world, one in Seattle, one in Monterrey, Mexico, which is kind of a middle-income country, and one in Kamashu, Ghana. What you see here is this is basically the proportion of people that were able to get to the hospital within an hour from having an injury. In Seattle, it's quite good. But in Monterey and Kamashu, it's about 55 to 50% of these patients make it within an hour. And from what we know about the golden hour of trauma, this clearly bears out in survivorship. So this here in the black is your percent chance of surviving in Ghana, which is about 37%. And then we find that a large portion of these deaths is actually pre-hospital deaths. And when you get down here into the ER and hospital deaths, it's actually fairly similar. Getting to the hospital is one thing, and getting to a hospital that you can have orthopedic care is another. So this is the United States. We have 28,000 orthopedic surgeons. Malawi has 17,000 people, which is approximately, or 17 million people, which is approximately Florida has 9. And this is actually much improved over the recent years because they've developed an orthopedic residency program and has been able to retain some residents. Extrapolated over the whole United States, this is actually 205 orthopedic surgeons, so we would be quite busy. And if you actually look at Washington alone, there would be 4.2 orthopedic surgeons. So you can look around the room and pick the 3 colleagues that you like the most and realize that you guys are going to be pretty busy together. This is the hospital I worked at in Malawi, and I'll be honest, this is kind of an extreme example in the sense that this is really a critical access hospital for one of the poor countries in the world. But this is our ambulance bay. So if you happen to get to this ambulance bay alive, and you happen to be there when, like myself, was there as a medical student interested in orthopedics, we might be able to try and take care of you. But then you'd go to the supply room, and this is what you would find. So there's some IV fluids, which actually ran out when I was there at one point. Some IVs, some sterilization equipment. There is another supply room, but there's not much in there either. But intermittently, we actually ran out of the following things. So we ran out of plaster once, and we ran out not infrequently of absorbable suture, which really prevents you from the ability to do much of any surgical intervention, as well as things like antibiotics and anesthesia agents. Some of this was just the nature of the place I was working, but some of it is also the ability of countries to spend money on healthcare. And this is information from the World Bank. The United States is on top, which really isn't fair because our healthcare spending is almost as much of an outlier as these other countries. But this gray line here is Brazil, spends about $1,000 a year. And if you can't see it, this gray line, which is also the x-axis, is Malawi, which spends $26 a year. This was pretty staggering to me. I didn't know it was actually that low. But this is actually on par with a lot of the countries in the region. And relative to the amount of money they make from a gross domestic product, it's fairly similar. So I hope I was able to set the stage. We'll go ahead with Dr. Bransford now, and he'll present us on some of his work. Thanks.
Thanks, Calvin. And I'm going to share mainly stories because I think that it certainly sets some of the framework, and I think Calvin sort of laid a nice structure to kind of give you a little bit of a reference of sort of where things are at. So I'm Rick Bransford. I'm based over at Harborview for those at other institutions that we don't cross paths with. So these are the issues I want to try and cover, and I think looking at the background to my work, I think that's critical because I think I have a substantial upper hand compared to most people just based on my background, and I'll share that with you. And then want to cover these various other aspects kind of in order to try and, again, give a framework and what I see in, as I travel overseas as some of the challenges and how you overcome those and how you work within the system and how you pick and choose your battles. So looking at the background to my work, I grew up in Africa. I grew up mainly in Kenya. My dad, who's pictured here, still has recently retired at age 75 to North Carolina, but he's actually going to Somaliland again this coming week, and he goes back about 5 times a year. He's going to go through Egypt on the way. He's regularly traveling around. But my father, who's a general surgeon by training, spent a 45-year career in East Africa working as a missionary surgeon. So although he's trained as a general surgeon, he does plastic surgery, he does orthopedics, he does neurosurgery, he does general surgery, he does obstetrics and gynecology, you name it, he can do it. And so when I kind of look at his career, he spent probably the first third of his career as a general surgeon doing everything. Basically starting out his career in the Comore Islands, which is an island of 250,000 people. He was the only surgeon. So he would frequently go to the operating room with a textbook beside him, and basically this was the advent pre-email, pre-even phone calls on a certain level. You just sort of did the best you could. And so he started out in the Comore Islands. He then sort of the mid-third of his career was largely orthopedics. The latter third of his career was largely pediatric neurosurgery, sort of morphing into what needed to be done based on the situation and where the need happened to be. And basically say, in medical school we learned anatomy, we know surgical principles, you just put those two together and you can kind of make it work. So being raised as mainly in Kenya, here I am operating with my dad. I started watching surgery when I was 6 years old. I started assisting when I was 12 years old, and I nailed my first femur when I was 20 years old, so by myself. So again, I sort of had a little bit of a unique perspective in that a lot of the pathology that Calvin talked about, I sort of started to see when I was in elementary school, and so I kind of knew a little bit of my way around the operating room in a third world country. So I think that sort of put me in a bit of a unique position to sort of deal with some of the issues that Calvin talked about, and I think that sort of, again, maybe makes it a little bit easier for me to do some of these things than for other people. These are the various locations that I've worked in a third world capacity. I spent about 10 weeks in Indonesia. Similar to Calvin being in Malawi, I spent 10 weeks over there as a medical student, and they didn't have an orthopedist on the entire island, so I became the orthopedist as a fourth-year medical student interested with my background. I also did all the plastic surgery as well as a medical student. I spent a little bit of time in the Philippines. Again, Kajabi, Kenya, here is where I grew up. And then most of my stories that I'll share today will be based on Somaliland, where I go once or twice a year for about the past 6 or 7 years now, and have made about 8 trips up to that area of the world, and I'll show you where that is. So this is where I grew up. So this is Kenya here. This is Africa. So this is the Indian Ocean. This is Saudi Arabia up here. So to give you a little perspective, so Kenya's right here, the equator runs right through it. I grew up about 50 miles south of the equator, about 50 miles outside of Nairobi, in a place called Kajabi. This is the area where I've been going once or twice a year. This was the classic Somalia here that included this as well. This is now separated out to now be Somaliland. And this is where my dad goes about 5 times a year. I go about once or twice a year. And if we break this down and look at this map, here's Ethiopia over here. There's 2 areas that I've really worked here in Borma, which is right on the Ethiopian border. And then more recently, we sort of set up shop in Hargeisa. And so when you see the pictures, most of these are going to be coming from here. Now to give you a point of reference, to drive from here to here will take you 18 hours. To drive from here to here, which is less than 100 miles, this will take you 3 hours. So again, to kind of give you a bit of a perspective of what the people kind of face as they're trying to get around. And whenever we go there, they actually send a text message to everybody who has a phone in this entire region and down into Somalia, down into Mogadishu. And so from Mogadishu to Nairobi or Kenya is not that far, but these people can't cross this border, so they come all the way up to here to come get medical care up there. So I want to talk a little bit about, and I'll show you a lot of pictures here about working in pathology outside of your comfort zone. And when I say this, I could spend a 50-year career here in this country doing orthopedics, and I mainly do spine, but I would never see the stuff that I see when I go over there. It's just it's a different residency, it's a different training program altogether, and a lot of it you just sort of have to be trained on the job, if you will. So these are a lot of the common things I see, and again, you can look at these and say, well, these aren't that uncommon in the first world until you sort of break down and look at the issues here. So I do a lot of clubfoot surgery, a lot of burn contracture surgeries, a lot of osteotomies. You see things like post-polio syndrome. You see nonunions, malunions, but in very old fractures, and again, I'll show you sort of the framework in which these patients come. Do a number of amputations, largely from old mining accidents or from AK-47 injuries and stuff like that. And then there's some of it you just go, I don't know what this is, but I think I can make it better. And I'll show you some stuff like that as well. So I was over there in Somaliland about a month ago, and this was my first full day there. This was our operating list, so Bransford includes myself and my dad. So I don't do all of these, but if you look on here, there's 7 clubfoot procedures in one day. So here's a bilateral. Again, this was written out by a Somali. So left foot deformity, this was a clubfoot, right clubfoot, bilateral clubfoot, clubfoot. And you come back and look at the ages. Here's a 6-year-old, 3-year-old, 12-year-old. So 7 clubfoot procedures in one day. So I haven't been to children's, and I'm sure, I don't know if Dr. Mosk is here, but I'm sure if we ask them how many clubfoot procedures you guys do from an operative reconstructive standpoint, like a circumferential release, I bet you there's probably no more than 3 to 5 a year total. In our catchment area of the entire Northwest, here's 7 in a day, and this is not an uncommon day. I usually do at least 2 or 3 a day, clubfoot procedures. And so these are not uncommon. And so, this is the typical, you walk around the hospital, you see a kid like this with a clubfoot, a lot of bilateral clubfoot, here's a clubfoot. And, this is basically going back to, these circumferential releases, doing all the joint releases and tendon lengthening and stuff like that, that are not that common in today's world, in the first world. Here's a kid here, here's another post-op, but this kid here, you can see bilateral clubfoot. I can't remember how old he was about 8 years old. He and his father had walked for 10 days to get to the hospital to basically have their clubfoot taken care of, and we typically, in the first day, we'll sign up 50 cases for surgery within 3 hours. This is not a long, lengthy history or anything. This is not operative consent. This is like, do you want your clubfoot fixed? Yes. Okay, we'll do you tomorrow. End of discussion. And that's about as far as it goes. But this kid had walked for 10 days on his club feet, you can see here, to kind of have these fixed. And so this is the sort of stuff you see. You see kids that are 3 or 4 or 5 years old, even up to 12 years old. So a number of triple arthrodeses and stuff like that as well, where they're just sort of beyond kind of the basic reconstruction. And this, fortunately, is changing on a certain level, but still a big issue. Here's some more other foot kind of deformities, but there's a lot of foot deformities. When you kind of look at it and say, these people live on their feet. There is very little automotive transportation. They're farmers, they're herders, They're kind of walking to the market. They got to be able to walk on their feet. And so the saving grace in this is that these are operations that can be done largely with sutures and plasters and don't require a lot of orthopedic equipment. And so this is one thing that can relatively, in a straightforward way, be taken care of with minimal supplies. One of the other things that I end up doing a lot of are burn contractures. And so, you know, in here, if a kid gets a burn, they come straight to the hospital. They get this immaculate burn care day after day after day, and they don't develop these contractures. Here they have a lot of open fires in the ground, as you can imagine, in a third world country. So they're frequently, the kids fall into the fires. And what happens with the ladies is depicted here. There's three different stories that go on. One idea is that these ladies that are girls, I should say, that are really set up to be married at age 12 to some 40 or 50-year-old guy, and they're going to be their fourth wife. They try and commit suicide, and what they do is they put water in the kerosene lamps. The kerosene lamps blow up, explode onto their chest, and in hopes that they're going to die. And if not, they end up significantly maimed with like burns across the chest. Seem to be about 4 times as common in the girls or in the women as in the boys, but you see a lot of this. And so I'm an orthopedist, but you know, we can release this, do kind of full thickness skin grafts to try and improve on the cosmesis of this, at least get her chin off her chest, allow her to close her mouth. And so sort of reaching a little bit outside my comfort zone, but sort of with doing 1 or 2 or 3, you kind of learn how to do these. You can see these burn contractures, very mature burns, scars here, you know, fingers kind of curled down into the hands, and can essentially do a release of these burns, take a full thickness skin graft from the groin, put this into here, and then we use K-wires to kind of hold the fingers in place. So here's a couple of other post-ops here where you can see the fingers, the wires down the fingers, releasing this graft, and hopefully allow for a hand that's going to be more functional, again, in a culture where these people have to survive and where they have to make the best of it. And so one of the other things I end up doing besides Clubfeet is a lot of burn contractures, as depicted here, that really, as you all know, is not something I do here at all, but something that is relatively straightforward, relatively resource unintensive, if you will. And so these are a lot of the other pathologies that you see here throughout the third world. You know, this is Somaliland, but it's no different in Kenya. It's no different in Indonesia, where they're sort of largely cooking around open fires. You can imagine you have a 2-year-old, he sort of falls in, puts his hand in, gets a severe burn, and they don't get any care. End up doing a fair number of osteotomies. This was a girl, this x-ray here was from a girl who was, when she was 8 years old, she was in a road traffic accident. Calvin highlighted how when they do have these cars, there's no safety belts. You basically stick, you know, 20 people into a van, and when that thing gets hit or rolls over, you know, everybody gets hurt. But this girl, when she was 8, she's now, I think she was 12 at this picture here, had this injury. She had a peroneal nerve palsy. And you can see the growth arrest here, both in her femur and in her tibia, and this was her alignment. And so, again, there's no C-arm, there's no implants of significance, so a lot of this ends up being plaster and K-wires. So I did a closing wedge osteotomy here of her proximal tibia. Here she is in the operating room. You can see my K-wire through here. You can see my incision. And here's what she looks like post-operatively. So again, it's not perfect. I don't have any C-arm. I'm sort of making the best guess I can. I'm trying to calculate how much of a wedge I need to take out. I'm trying to make sure I get this. And you can see that I think I've improved on her alignment. And then if you look at her, this is her when she came back. She came back, and you can see that she's still got a foot drop, she's still got a leg length discrepancy, but at least she has some component of a straight leg. And again, something that with a little bit of plaster or K-wire, you can substantially change the future of some of these people. And now this girl's about 13, 14 years old. You know, hopefully she can have some sort of meaningful, productive life. A lot of other kids that come in with various deformities. This was a boy here. You can see the varus in his legs. This was a girl who was 12 who has osteogenesis imperfecta. Had never sought care before, and so obviously she can't walk on these legs. So I took her, and again, you got to be a little creative. So I essentially took did a closing wedge out of her anterior tibia, cut her fibula, osteotomized her fibula, took out a piece of her fibula, and used that as sort of an inner body device, sticking her fibula up into her what was left of her tibia, and down the other side as sort of an intermedullary nail, if you will, and was able to get her corrected. As you can see on this side here, quite straight on the right leg, and here she is in her plaster, and I was going to do her other leg kind of a few days later. She decided that the pain was too great and the family wanted to hold off. But again, sort of, being a little creative, taking her fibula and being able to use that as an intermedullary device, could actually make this crooked leg quite straight and allow her hopefully to eventually walk on this. Here's some other kind of deformities, and I have to say that a lot of these, I don't really know what they are. I did a pediatric fellowship, but I don't know why these kids end up with these sorts of things and why these deformities there, but end up doing various osteotomies and you can kind of make crooked legs straight. I think Carla will probably talk a lot more about fractures. I have used the sign nail there. We don't actually have one at this hospital, so we had to sort of borrow it from somebody else. But there's a lot of old trauma. This was a guy who was 18 years old. He'd had this accident about 4 or 5 months ago, and he essentially had healed or was healing in this position here. And so again, there's no C-arm. You can see I have a third tubular plate here. But really not much in the way of kind of periarticular plates. And trying to make it up as we go, I was able to sort of osteotomize through his fracture, get him straight, and kind of blindly, you can see I sort of missed, stick this big wire up through his calcaneus into his tibia to try and hold him in position, put him in plaster, and can hopefully give him something that's at least plantar that he can walk on. And so I think you can improve on a lot of this stuff with very minimal equipment. This was a guy who had a femur fracture. He was about 8 months out, and you can see this proximal femur fracture, how that's healed, all this callus formation up in here. This is kind of another day in Africa, if you will, with these people who've been sitting around, lying around in their huts or basic homes. They hear you come, and they're like, what can you do for me? As you can envision, too, one of the other common pathologies is osteomyelitis. How in the world does a young child have this piece of bone sticking out? Here it is here, who's been living with this for over a year. And this is not that uncommon, but relatively straightforward and quite easy to take care of, to just sort of go in there and take this out. This was a piece from a femur that I took out of a young boy, and so you can get a sense of the reference size of this. This was close to a foot long, or at least 12 centimeters long, coming out of his femur. But these kids are living with these draining sinuses out of their thigh from this chronic osteomyelitis. And so again, sort of some basic surgery can go a long way in helping some of these kids. And then there's other things, I just sort of say, this is Africa. This is a snake bite. So this is a burn contracture from a snake bite. This is a fresh snake bite that this kid came in and was 2 days out from a snake bite and ended up losing a substantial portion of her arm as it just sort of all necrosed. This is a tumor of sorts. There's no real pathology there, so I did a ray amputation here. I don't think I cured it, but hopefully we'll give her some quality in the remaining time she had, and who knows what it is, who knows if it metastasized or anything, you don't know. This is a guy from Ethiopia. He had this chronic fungal infection through his foot and through his bones as well, from basically working in sort of wetlands and being barefoot. This was sort of a leg I did an amputation on, and I took this picture largely because the whole operating room was empty at the end of the day, and this foot was sitting in the corner. Nobody had disposed of it. It was just sort of sitting there on the floor. And so, you can see sort of the quality of the tissues here. This, I think, was some sort of form of Proteus, but in a culture where these people are barefoot or wear flip-flops most of the time, how do you get this into a shoe? So I ended up sort of debulking a lot of this and sort of doing amputating across these three, leaving these 2 small toes here. So this is sort of the stuff you see. So I want to talk a little bit about education, because I think that as Calvin pointed out, you look at the statistics there, and education I think is a critical part here. So again, this is my dad here. This is a group in the operating room. These are a couple of the Somali doctors, and I'll use doctor term loosely. But collectively, my dad started going there about 10 years ago. At that point, they had sort of a fledgling medical school. But over the 10 years, these 2 people are outstanding surgeons. This is a lady named Rhoda, who's actually doing a formal orthopedic residency in Kenya right now. This is a lady named Decca. And Decca has done all of her training in Somaliland, largely under the training of my dad. But right now, I'd say that she could probably fix a clubfoot better than most of us in this room. And when I do these bilateral clubfoots, I'll do one side, she'll do the other side, and I'll sort of check off on it. But it's sort of, this is the future. So they start medical school, and again, I'll use that term loosely, after about a year of undergrad. In their medical school, most of it's sort of from the books and from the internet, and then they sort of do the rest of it on their own. And so a lot of it is you just go there and they work with you, and the first case, you do the whole thing. maybe by the 10th case they're suturing, and by the 20th case, they're doing a little bit of it, but after a while they sort of get it. And these two are excellent surgeons at burn contractures. They're good at doing hydrocephalic shunts, at spina bifida closures. A lot of the stuff that we do that we don't. My dad does a lot of these things quite commonly, and a lot of these, the orthopedic stuff, they've learned. And very happy-go-lucky people. But they're the future, and they're learning, and they're actually taking care of a lot of this stuff when we're gone, which I think is critical, too, to maintain that link to take care of things after we sort of move on. So one of the big issues, I think, with traveling overseas is who takes care of these issues when you're gone. So what links do you have? And so sort of tailoring off the last one, education is key. These people now will email me regularly and say, this patient is doing this, what's the next step? They sort of recognize the complications. They can kind of take out the K-wires. They can kind of manage the cast. They can see when there's complications. Building links, one of the big links that we have now in Hargeisa is Handicap International. It's a group now that's with their therapists there doing the Ponseti technique. They're doing the bracing afterwards, the AFOs. They're putting patients in functional braces. They make prostheses and wheelchairs. So having them come to the clinics and stuff like that is incredibly helpful. There's the local doctors I mentioned earlier who really are sort of the backbone now of what's going on there. And then I think for most of these places we go in the world, there's still international links. When I go to Somaliland, which I think is sort of one of the most remote places in the entire world, there are Western family practitioners who live there 100% of the time, and they can help manage stuff and they can help communicate. My dad's schedule, he goes about every 8 to 12 weeks, so he's there sort of with that schedule. He's seeing the follow-ups and he can manage some of these complications. And then the doctors there themselves. But I was telling Calvin when we came in here, I had one kid that sloughed I did a Clubfoot release in a 5-year-old, and she sloughed her incision. She ended up in Ethiopia with a plastic surgeon there who was trained in the U.S. So there is sort of this vague network of options of people to get there to manage these complications when they do happen. And again, I think with that you have to pick and choose your battles because you want to pick largely things that are going to be relatively low in complications. So the last thing I wanted to talk about was just sort of making it work. We're sort of used to having, you kind of ask for the particular rep to come in with a particular implant. It's not there, and Calvin sort of alluded to that, when talking about running out of plaster and stuff like that. So I think with that, you want to choose your battles. You want to choose ones you can win. So despite being a spine surgeon, I've done no spines whatsoever in Somaliland. I don't think they're ready for it. I think the infection rate would be too high. I don't have the implants to do it, so I just haven't gone there. Much less, you don't have a C-arm. How am I going to know what level I'm at, even for a decompression? So that's another thing that can be challenging, and you can sort of make some of these things up. But these are some of the battles you have, and so I think you got to pick carefully which ones you think you can win and which ones you kind of want to just say, there's other people, there's plenty of other people I can help. This is one that I will not be quite as successful. I'm not going to do this. You do a lot with plaster. It's amazing what you can do when you just come back to simple plaster Paris and just sort of realign injuries or bones or whatever, and then put them in plaster. End up doing a lot with K-wires because there are no nails, there's no periarticular plates, there's not a lot of this other stuff. And again, you can make it better. And I think one of the things that I've learned is that I'm the only orthopedist that goes there. So in the past 5 years, I think I'm the only orthopedist that's been in this area of the world. And so my best shortcut, if you will, and again, don't want to sort of get too carried away and trying to say, well, we're doing experimental stuff. But my best shortcut is likely better than what anyone locally can offer. They still have witch doctors. I've still seen kids that have pretty severe finger contractures because they were basically put in plaster Paris that was just wrapped too tightly. And you basically create a compartment syndrome. And so what I can offer some of these people is likely better with K-wires and plaster is likely better than what anybody else can offer them at that point in time and probably in their entire lives as we try and improve on their quality of life. So again, remember, it's all about the people. You can see these kids. These are people who are born in a society where they're living on $600 a year. They have a poor life, and whatever you can do to improve on it, it's really about them, and it's amazing how rewarding it is, and it really sort of puts my feet back on the ground to go over there and come back over here, and you really take for granted all you've got. Here's some of the people that go regularly. Anybody who talks to the anesthesiologist knows this guy, Mark Newton. He's basically out of Vanderbilt, but he has done more to revolutionize anesthesia in East Africa than probably anybody in the past 100 years, developing training programs and stuff. Here's a general surgeon trained out of Nebraska. He goes up there regularly. Here's my dad. This guy's a family practitioner. And all these people regularly, all four of these others, regularly go up there and invest in training these people and hopefully taking this to the next generation. So again, here's sort of Africa that Calvin showed earlier. Malawi's down here. This is where I grew up in Kenya, and this is sort of the area up here. So if anybody has any questions or thoughts later, you know, always excited to talk about this, and anybody who ever wants to go, the opportunity is there.
Good morning. It's tremendous fun to come back to the University of Washington. 15 years ago, I sat in the very seats that you're sitting in now, with a whole world of opportunities in front of me. And the chance to come back and to share stories with Rick, with Calvin, is truly enjoyable. Overseas, all of you, everybody in this room, went to medical school because you're smart, because you worked hard, and because you wanted to help people. All of you want to leave the world a better place than you found it. And overseas humanitarian work is only one way to do that. It's what we're talking about this morning, but I would have all of you think about what ways you give and how much you get in return for that. I'd like to use a couple of stories to illustrate some of the unique challenges that overseas work provides you, especially logistically, ethically, socially, and more importantly, how those actually represent opportunities for you to challenge your brains, to give back, to accomplish something that's unique to you. This is Nepal Orthopedic Hospital, about 4.5 weeks after 3 earthquakes rocked the Kathmandu Valley. Normally a 100-bed hospital, there are 400 patients housed in these temporary tents. And I convened a meeting of the 29 sign surgeons that are active in the Kathmandu Valley and a few others who had taken care of the victims of the earthquakes to revisit the events after the earthquakes, to sort of summarize what had gone well in the response and what we could do next time to be ready. And overwhelmingly, the surgeons said crowd control was a problem. First of all, the patients rushed out of the buildings after the earthquakes. They could not get people to stay inside buildings. And that got worse as earthquake after earthquake happened. Secondly, the new injuries that were arriving every day from the neighborhoods. But thirdly, the media. Bulan Thapa is the head of the trauma for the Ministry of Health in Nepal now, and the head of the government hospital, Bir, which is in Kathmandu. In the aftermath of the second earthquake, he recognized that his 100-year-old facility, already decrepit, was now unsafe and becoming non-functional. And he used that crisis as an opportunity to move into a new hospital that had been built adjacent by the Indian government, but had been left empty for 5 years because of political bickering. Hampering that was a well-known neurosurgeon from one of the Western networks, whose VIP entourage got in the way physically of moving into the building, detracted attention from the work at hand, and took people away from the patients who were in need. Furthermore, the claims by this individual that he had performed life-saving surgery in that hospital were debunked both by Dr. Thapa himself and the parents of one of the children, who claimed that he had been nowhere near that hospital in the days after the earthquake. And so something as simple as record keeping undermines the credibility of humanitarian efforts. Going back to Nepal Orthopaedic Hospital, they have 400 patients now in wards A, B, C, D, and E labeled simply by placards hung from the front of the tents. If you look here, you see a real simple paper number attached to the foot of the bed, matching the number attached to the patient. Furthermore, every dressing that went on in the aftermath was timed and dated, so everyone knew when it needed to be changed, and on it was written the surgery that had been, if surgery had been undertaken, the time and date of that, a very simple record-keeping method that proved effective for the U.S. military in moving injured soldiers from the advanced field hospitals into the European theater as well. The other thing that I would point out in this is that present in this photo is what I think is going to revolutionize our ability to keep good records, especially in this environment. Who sees it? Say it. The cell phones, right? These are indigent, I mean, these are poor people. They don't have money for healthcare, they don't have money for food in the aftermath, but they've all got phones. The cell phone technology and network is so pervasive now. It's a glaring opportunity for some young, smart mind in this room to create a cloud-based record-keeping system that could keep track of all of this safely and securely. It's right there in front of us. One of the ways we've addressed this through the nonprofit Fracture Care International, formerly known as SIGN, is that part of our endeavor has always been about the record keeping. It's the price of the implant shifted from the patient to the surgeon. So any surgeon that implants this has to give us the data regarding the case and, importantly, the clinical x-ray follow-up. You get to laugh at this. This is 13 years ago, fresh out of fellowship, full of naivete and optimism. I headed over to Nepal Orthopedic Hospital to introduce them to the SIGN nail. This is our first workshop there, and you can see one of the small technological tweaks that overcame the logistic of not having a C-arm available to you in an austere environment, and that is the interlocking capability that the SIGN nail creates without C-arm. And the ability to interlock a nail is really critical to achieve good fracture care. Length, alignment, and rotation are much better preserved with the ability to interlock. This is the first case we performed together at that hospital. This is one of the houses about 30 miles away from the center of Kathmandu, at the epicenter of the earthquake. All 5 members of the family died in this house. This is a neighboring house. You can imagine the reconstructive challenges here. There's a bunch of teenagers on the roof that are deconstructing the damaged structure brick by brick, saving what they can so that they can rebuild the whole village. Our disaster response really started 13 years ago when we started bringing SIGN to the hospital, when we created the ability to treat a lot of the long bone fractures safely, when we kept track of those results. And currently, Nepal Orthopedic Hospital has the greatest number of cases treated in Nepal at about 1,300, 800 of which have follow-up data on the database. Pretty good, even compared to a US trauma center. Importantly, I would also say that it's the communication that we've engendered. It was the surgeons working together in the aftermath of the earthquake, talking to each other, figuring out whose hospital was still standing, who could still operate, that set the groundwork for a lot of the successes that they enjoyed right after the earthquake. Taking care of fractures in an austere environment during normal times sort of was the groundwork. And the fact that they knew each other and communicated and could take implants back and forth helped as well. There were 60 patients treated in the field hospital tent at Nepal Orthopedic Hospital, another 20 that were treated at a couple of other operating facilities, and up to this point, which is now 6-month follow-up, of all of the closed fractures, which was about 87% of all the fractures, we've had no infections reported, and the fractures are healing accordingly. And so it's data like that that help underscore our credibility. One of the other challenges I would leave you, follow-up is a big problem. Knowing that patients heal when they go back into the remote villages and don't come back, you assume they're doing well, but you don't really know. I have every confidence that somebody in this room could figure out an app for your smartphone that you can take out into the village, and either via ultrasound or via infrared, or somehow you can quantify the callus present around the fracture, and we can say, yep, these are healed. They no longer have to come in for x-rays. What incredible technology that is. We can get all the way out to the patients in their villages. Ethical issues. Rick had talked already a little bit about consent. Outcomes are critical. you can't just experiment on people when you can't obtain consent from them. And in bringing new technologies, I think, Rick underscored, help the people that you can help. This is Joseph. He's a very enthusiastic chief resident at Muhimbili Hospital in Tanzania. I was part of the combined Sign I Got AO course a year and a half ago. And part of that course involves going to the operating room and operating together with the residents there and the faculty there. As the patient was getting a general anesthetic, I said to Joseph, this is unusual. Spinal is really the norm in most of the lower income countries. And he said, yeah, well, this patient's a prostitute, and she has untreated HIV, and she's psychotic. And so she's been on the ward in traction for about 4 weeks. And she gets confused and combative, and she tries to stand up and move around. And her screaming is unnerving all of the other patients. And so we thought we should fix her femur. And that took me a second. And I thought, wow, okay. She has no family. And then I recall the conversation I had had with an ethicist at Sacred Heart in Spokane, who I really respect, regarding kind of a similar patient at home. A psychotic individual, had a gangrenous foot, incredible pain from vascular disease in his leg, but really not someone who can consent in the form that we like it to take legally. And he was able to convince me gently and appropriately that there was a higher principle, that ethically providing the palliative care of pain relief for this gentleman was the right thing to do. And I think that's how I came around to accept that certainly allowing this lady to get up and move around and not tying her down in bed and not having her flail against the traction was probably the right thing to do. And I don't by any means give you that as the right answer, but it's a question that you ought to examine in any environment that you're in. The very mundane social logistical concerns. Is this for you? In hot countries, it's hot. In cold countries, it's cold, and that pervades the ward, the operating room, everywhere. It's often smelly. The same course in Tanzania had a cadaver component. And there were a number of Westerners who sort of walked into the claustrophobic, hot, small room where the cadaver dissection was going to be undertaken and just walked right back out. And I admit I almost joined them when the cadavers rolled in. And they were young males, still had their street clothes on. They were still warm. One had an obvious femur fracture and a head injury. And they'd clearly come straight from the casualty ward, or department rather. Probably enjoyed that golden hour on the street and didn't make it past that. And they were cadavers. And took me a few minutes, but as I was standing there were 120 surgeons from East Africa who attended this course. And they were crowded around us. Jim Fick was dissecting the foot on the same cadaver in which I was doing approaches to the elbow. And the participants were just so eager to learn. They were all crowded so close in, and standing right next to me were two women, medical students, or actually early residents at Muhimbili, in full burqas. And if they could withstand the heat and the smell, so could I. On we dissected. But that's not for everyone. And so you should really examine whether that's for you. If it is, great. If it's not, there are plenty of other ways that you can contribute. Oops. The other thing I would say is that once you start, it grabs you. These guys are the Nepal orthopedic surgeons. They're now my friends. Most of them have been to my house. I've been to all of their houses. You will find yourself needing to give more and more and more, and that becomes its own challenge. These guys are in an environment where everything is hard, and that you have to balance yourself. But I'll have to tell you, it's really rewarding. If you want something you can do right now, look up these AMA publications. Hopefully they'll spark some element of humanitarianism here or abroad and give you an outside perspective. There are other things you can do. Orthopedics Overseas has multiple grants for residents or new graduates to visit one of the established programs. It's sort of a way to get your feet wet to see what it's like. The Sign Conference is held annually, as is the Orthopedics Overseas Conference. One's at the Academy, the other's in Richland, which is just a few hours down the road. The database that we have at Sign is begging for projects. We've got nearly 90,000 long bone fractures treated with Sign nails on that database, open for mining. And then just think about how humanitarian work plays a part in your life. It may be as simple as volunteering once a year at Habitat for Humanity. It might just be checking in on your elderly neighbor. But it could be overseas work. And I think we are all open to telling you how we've gotten involved, what things that you can do, and how it's changed us. And if you have any hesitation in taking that first step, remember that any journey, even of 1,000 miles, starts with a single step. Thanks.
Thank you, everybody. But we have a little bit of time for questions. Oh, yeah. We also just recently confirmed Dr. Zirkle from Sign is actually going to be coming in December for the residents, and we're going to have a workshop. I think it's on a Wednesday afternoon, the 3rd or the 4th. So that's out there.
He thinks it's the 2nd.
Maybe it's the 2nd.
I think, you know, the one way to measure grand rounds is not necessarily by the number of questions. I think it's how deeply we're all going to be thinking about the topic after we leave today. And I think this grand rounds is probably going to have a big impact on all of us. Appreciating what we have here, appreciating how great it is that some of our colleagues and former residents are, you know, have dedicated so much of their lives to this, so thank you.
Thanks.
The only other comment I would have is I think Carla made a great point. You know, this isn't for everybody, and I think one of the things we can't forget is that, you know, this is wonderful work, but we have lots of needy patients, you know, right in our own backyard, and I think one message to take from this is the next time, you know, you see one of these HIV, you know, psychotic patients here, or, you know, a patient without insurance, there's a way to make an impact at home too. Obviously, I would encourage all of our residents to get involved with the overseas work, but let's not forget there's plenty of humanitarian deeds we can do in our own backyard. Thank you.
All right, thanks, everybody.